Hello guys. So I told you that I'll be coming up with the video explanations of this ophthalmology quiz for Orbit, because I found that many of the questions were having some or more doubt. So I thought, why not giving you the video explanations? Okay, so let's see the question number 1 here. We have a child who is presenting with unilateral proptosis. Now this proptosis cause is compressible and it is increasing on bending forward. It is non-pulsatile, no thrill, no brew. And what is the MRI saying? MRI is saying there is a retroorbital mass with the echogenic shadows. What is the most probable diagnosis? So how you are going to approach this question? Now if you directly see unilateral proptosis in cases of children, then the answer that comes first in the mind is the orbital cellulitis, right? Because it causes unilateral proptosis, but that is not there in the options. So what is the second thing that you have to pick? The second thing is that it is causing the non-pulsatile kind of proptosis. There is no thrill, no brew. So if you see carefully the three options which are given in the question, the orbital encephalocele, the orbital AV malformations and the neurofibromatosis. These are basically causing the pulsatile. They are causing the pulsatile kind of proptosis. So the only cause which is causing the non-pulsatile kind of proptosis in cases of children will be your orbital varix. Now we have other things also which will be correlating well to mark the answer, because you know varix, where we have a problem with the veins. So when we have this problem with the veins, this kind of swelling that we have is actually compressible. It is also increasing on bending forward and it is present in the orbital space. So obviously when I do the MRI, I'll get a retroorbital mass along with the shadow. So now everything is actually explained by the orbital varix. It's a common cause of unilateral proptosis. It will not show any brew. It will not, because you know brew and this thrills are found whenever we have deficiency of the roof. So that can be found in cases of encephaloceles, or you have some malformations, and that is why they also have the pulsatile kind of proptosis. So that is not there with the varix. And second thing is the varix is compressible and it will be increasing on bending forward. So your answer will be orbital varix. Coming to the question number 2, following a RTA. So what is RTA? I think even if you have gone to the casualty on for one day, you will come to know within 1 hour what is RTA. It is a road traffic accident. So on 4th day, so this patient is coming to you on 4th day, person developed proptosis and pain over the right eye. So again we have proptosis, we have pain following the road traffic accident. On examination we have brew over the eye as well as the forehead. Now what may be the diagnosis? What may be the diagnosis? Now always remember that whenever you are having the proptosis in terms of the trauma, like here we had a road traffic accident, then there was a brew, there is a evidence of the trauma to the eye as well as forehead, and then the patient is developing the proptosis as well as pain. The first thing that should come to your mind is actually the fistula. The fracture sphenoid is not a common thing, that is just taking place after the road traffic accident. Now you have got 2 more options, cavernous sinus thrombosis and internal carotid artery aneurysm. So both of these things, the thrombosis and aneurysm, are not related to the trauma. So what is that one proptosis which is actually related to the trauma? It can be the Keratico, Cavernous, Fistula. So in this way you will be able to give the answer, because they have not given you the signs and symptoms. They are just trying to see whether you can correlate that which kind of proptosis can be occurring after the trauma or which one is pathological. Right. So if I am talking about the cavernous sinus thrombosis, or if I am talking of aneurysms, then these are the pathological conditions. So I'll not say. Now fracture can occur after a road traffic accident, but this patient is coming after 4 days, plus that is a more severe condition. So we will first go with the more common condition. So this is your cavernous fistula. Question number 3. Here we have a patient who is having a history of running nose and pain over the medial aspect of the eye, with the sudden onset of the fever, prostration, chemosis, proptosis and diplopia on the lateral gaze, along with the congestion of the optic disc. Which of the following is the most likely diagnosis? Now this patient is having a history of running nose and pain over the medial aspect. So what can you think of? We can think about this acute ethmoidal sinusitis. A patient having acute ethmoidal sinusitis will be having the running nose also and will be having a pain over the medial aspect. But can this patient develop fever, prostration, chemosis? Chemosis means the edema of the conjunctiva, the proptosis is there. Diplopia on the lateral gaze? No. The sinusitis patient will not develop, like fever I can think of. There can be fever and prostration. But definitely the sinusitis patient will not develop the chemosis, he will not develop congestion of the optic disc, and especially the diplopia. Because diplopia means the paralytic squint. So this means there is something which has caused the paralytic squint, and paralytic squint means that there is a palsy of the extraocular muscles and most commonly its nerve supply. So what can be the cause of this? Orbital cellulitis, cavernous sinus thrombosis and orbital apex syndrome. Now orbital cellulitis can cause the extraocular muscle paralysis. We can have the proptosis also, cavernous sinus thrombosis and orbital apex syndrome also. Now these can also lead to the extraocular muscle involvement. We can have nerve palsies, but they are saying that this patient is just having diplopia in the lateral gaze. Now this is the catch point. Diplopia will always occur when the patient tries to look in the direction of action of paralyzed muscle. So if I am saying that the diplopia is occurring while looking towards the lateral gaze, that means lateral rectus is paralyzed, because diplopia is always maximum when the patient tries to look in the direction of action of paralyzed muscle. So that is now highlighting lateral rectus, and lateral rectus is supplied by the 6th nerve, and the 6th nerve is passing through the center of the cavernous sinus. So you should be thorough with the anatomy of the cavernous sinus. The substance of the cavernous sinus have got two important structures. We have got the 6th nerve and we have internal carotid artery. Now can this cavernous sinus thrombosis correlate with acute ethmoidal sinusitis? Yes. After acute ethmoidal sinusitis, this patient can develop cavernous sinus thrombosis because there are tributaries draining. Can this be causing all the symptoms which are there? Yes, it will be a highly systemic problem. So it can cause the severe onset of fever, we have prostration, we have chemosis, we have optic disc congestion, we have got proptosis, and also because the 6th nerve is the first nerve to be affected, therefore there will be diplopia in the lateral gaze. So answer to this question is the cavernous sinus thrombosis. Why can't it be orbital apex syndrome? Orbital apex syndrome भी हो सकता है, because that can also cause proptosis, chemosis, prostration, that can also cause optic discongestion. Why I'm saying just the cavernous sinus thrombosis? Because if you look at the apex of the orbit, so what is there? At the apex of the orbit, we have annulus of Zinn, and from this annulus of Zinn, there are so many muscles which are coming out. Then how can I say that it is just the lateral rectus that is affected? If the orbital apex is affected, then all the four muscles will be affected and I'll get diplopia everywhere. But they are saying specifically that I'm having diplopia in the lateral gaze. So that is pointing towards the lateral rectus. That means the sixth nerve, and sixth nerve is passing through the center of the cavernous sinus. So I hope now it's very clear why the answer is cavernous sinus thrombosis. Question number 4, the most common primary intraorbital malignant tumor in the children. So I had given you a flow chart to solve such questions. It's very easy to solve such questions from there. Whenever you have tumors, okay, tumors in the eye, always first see whether it is primary tumor or secondary tumor. So it is the secondary tumor which are more common in the eye. This is actually the metastasis. The metastatic tumors are the most common tumors in the eye. Now these primary tumors can further be divided into two. That is your intraorbital tumors, or we have the intraocular tumors. Intraorbital tumors and we have intraocular tumors. Now in both of them we can have two kind, whether it is common in adults or children. So intraorbital adults, it is the cavernous hemangioma, then it is the cavernous hemangioma, and intraorbital children, then it is the rhabdomyosarcoma. Similarly, if I am talking about the intraocular, so here what I am getting, intraocular in adults is your malignant melanoma. This is your malignant melanoma, and intraocular in children is your retinoblastoma. Now what they have asked, they have asked you a primary tumor, then they have asked you the intraorbital tumor, then they have asked you in children. Yes or no? If you look at the question here, they have asked you primary, intraorbital and in children. So answer to this question is the rhabdomyosarcoma. So the question is not tough, but you have to be very careful regarding each word there, because otherwise just a change of one word will lead to the different answer. Question number 5. All of the following are the characteristics of the preseptal cellulitis except. The options are proptosis and chemosis, periorbital edema, unimpaired pupillary reaction, or the normal visual acuity. So answer to this question is proptosis and chemosis. So first you have to understand what do you mean by preseptal cellulitis. There is cellulitis, there is inflammation of the vital tissues anterior to the septum. Now it has not crossed the septum. That is why I will have normal visual acuity, I will have unimpaired pupillary reaction, because it is not crossing the septum. It is not going to the fibers of the nerves where the muscles are affected. And therefore, I will have just this periorbital edema kind of a thing. I will not have the frank picture like that I get in orbital cellulitis, like proptosis, chemosis, conjunctival injection, we have prostration, those things are not found. So obviously, I will not get the proptosis and chemosis in cases of the preseptal cellulitis. That is the main differentiating feature between the preseptal cellulitis and the orbital cellulitis. Alright. Then question number 6. Tolosa Hunt syndrome. What is actually your Tolosa-Hunt syndrome? Tolosa-Hunt syndrome basically means we have the granulomatous inflammation. Whenever we have the granulomatous inflammation taking place, right, this can be in the cavernous sinus, it can be in the cavernous sinus, or it can be the superorbital fissure, or at the orbital apex. So in other words, it can be a kind of a orbital apex syndrome also. So your options are orbital floor, orbital roof, then we have the orbital apex or the orbital space. So this is very direct, it is the orbital apex where the Tolosa-Hunt syndrome will take place. Next question, question number 7. A tumor has the following characteristics. So they are talking about a tumor which has the following characteristics. It is retrobulbar within the muscle cone. I'll tell you what is the muscle cone. It is well defined, presents with slowly progressive proptosis, easily resectable, occurs most commonly in the 2nd to 4th decade. What is the most likely diagnosis? So this is one question which is actually integrates ophtha with the pathology as well as the radiology, pathology and radiology, and I have done integrated videos with both pathology as well as radiology. You will get it on the YouTube there. Okay, so what is happening here? Suppose this is your orbit, okay, and we have the eyeball. Now at the apex of the orbit we have this annulus of Zinn, and from this annulus of Zinn is reaching the muscles like this. Okay, so can you see this cone kind of a thing is formed by the muscles? So this actually, this area I can say is actually your muscle cone. So we can have like this will be your intraconal area, and this will be your the extraconal. This is your intra and this is your extraconal space. So when I am talking about these intraconal spaces, the extraconal spaces, this actually relates with the radiological appearances that you are getting. We have a conal, then we have an intraconal, and we have a extraconal spaces there. So that means the tumor which we are talking about is actually present in the orbit, and second important thing is that it is between 2nd to 4th decade. So this is actually occurring in the adults. Now according to the flow chart that we have discussed, that means the tumor should be intraorbital and it should be present in adults. So what should be the answer? The answer is should be the cavernous hemangioma. So even if you do not have a clue about its capsule or its resectability, then also you are able to solve this question, because you know most common tumor of the orbit in the adults is actually cavernous hemangioma. If you know these other details, then I would say that that is also much better, but otherwise also you could be able to solve this question. Now if you see the other options, the capillary hemangioma is common in the children, right? And if I talk about the lymphangioma as well as hemangiopericytoma, then these are not found in the intraconal space of the orbit, or I can say the retrobulbar space. They are not found there. So that means you are there with your right answer, that is your cavernous hemangioma. All right. Now next question is, most common ocular movement affected in the thyroid ophthalmopathy. Now you should know two concepts in order to solve this question. The first is, when I am talking about the thyroid eye disease, what is the order of the extraocular muscle involvement? So the order of muscle involvement is IMS Lucknow. It is IMS Lucknow. That means we have first inferior rectus, then we have medial rectus, then is the superior rectus, then is the lateral rectus, and then we have the obliques. Right. So the first muscle which is involving is the inferior rectus. Now the second important thing, I know that you must be thinking then depression should be the answer, but it is not the depression. The reason is that the kind of squint that you get here is the restrictive squint, and this restrictive squint is taking place due to the fibrosis of the extraocular muscles. So what is happening? Suppose imagine this is your eyeball, right, and we have the 4 rectus muscle, something like this is there. Now we have the restrictive squint, inferior rectus. So inferior rectus is fibrous there. So now what will happen? This superior rectus is not able to elevate the eye, not able to pull this eyeball, because the eyeball is fibrous along with the inferior rectus, and that is why it is not the depression defect that we are getting in cases of inferior rectus. We are getting actually the problem of the elevation, because the opposite side muscle is not able to act due to the fibrosis of that muscle. So that is why the answer is actually the elevation. Then coming to the next question, question number 9, all of the following signs could result from the infection of the right cavernous sinus except. So we are talking about the right cavernous thrombosis, right? So let us see the options one by one. The option number A, constricted pupil in response to light. So that means they are talking about the light reflex. Now in the light reflex, you have got 2 nerves. One is your afferent and one is efferent. Afferent is optic nerve, efferent is third nerve. Optic nerve is intact in cases of cavernous sinus, but third nerve may we have the paralysis. Okay, so what is happening? You know that through the cavernous sinus we have got lot of nerves which are passing. Which nerves? If I talk about the center, then we have 6th nerve and the internal carotid artery. If I talk about the lateral wall, then it is the 3rd nerve, 4th nerve and the divisions of 5th nerve. So that means there is a high probability that these nerves can be affected. So pupillary reflexes will also be affected, and also we can have the ophthalmoplegias. So that means we will not get the light reflex. I will not get constricted pupil in response to the light. Engorgement of the retinal veins upon the ophthalmoscopic examination, but I can get the engorgement because there is a problem of thrombosis. So due to that I can get the engorgement of veins. Option number C, the ptosis. Now ptosis occurs due to the LPS palsy, and LPS is supplied by the 3rd nerve, and 3rd nerve can be paralyzed. So I can get the ptosis also. 4th is right ophthalmoplegia, so that I have already discussed that because all these nerves are at stake, they can be involved. So I can have the ophthalmoplegia. So what I will not have, because they are asking you except, so answer will be the constricted pupil in response to the light. Then finally the last question 10, the patient developed the proptosis and diplopia 2 months duration after the injury. Now this is very important. We are having proptosis and diplopia after the injury. On examination we have chemosis, we have conjunctival redness, we have external ocular nerve palsy. What is the investigation of choice? Now again the clue here is that the proptosis is taking place after the injury, so we will think about the keratico cavernous fistula. Now keratico cavernous fistula means that there is a fistula which is developing between the internal carotid artery and the cavernous sinus. High pressure area which is draining into the low pressure area. Okay, so what I would like, what will be the best investigation when I am going inside the artery and doing the angiography? Therefore the answer will be intra-arterial digital subtraction angiography. So I hope all the 10 questions are very clear. If there is any doubt, you can again post me and we can discuss it on the Telegram group or channel itself. Thank you and happy ophthalmology.